You are listening to the Innovating Cannabis podcast, where you will meet entrepreneurs, cultivators, scientists, doctors, and inventors in the cannabis industry.
I'm your host, Pam Schmiel, a freelance writer and journalist covering the cannabis industry. Today, our guest is Michael Sassano. He's a former Wall Street banker turned real estate developer and is known in the U.S. for building 16 large-scale cultivation facilities in Nevada. He left for Europe in 2019 to get a head start in the European cannabis market and launched Somai, a cannabinoid pharmaceutical company based in Lisbon, Portugal. Currently operating in 12 countries, Michael plans to be in 18 by year end. We discuss his global strategy and the obstacles he faces as a multi-country operator. Let's welcome Michael Sassano to the show. Yeah, if you could just give us an overview of where Somai's at, and then we'll just jump into the questions.
Okay, yeah. So now currently, Pam, Somai is in 12 different countries. We were shooting for 20 this year, but I think we're going to be at 18 when it all settles out. It's just a matter of development of new countries. Some are slower than the rest of them. So as an example, we started putting out a series of the countries and our partners. We like to publicize who we're working with, and just the other day was Switzerland. You're going to see, I believe it's next week or the week after, Italy. We did a whole partnership series on the launch of Italy. And many of these countries, like Italy and a few others, were only Ireland, were one of three, let's say, or New Zealand. And most of these markets are extract, not flower markets, these newer markets. They're going pure pharmaceutical and looking at the extracts, and clearly Somai dominates in that area. And then there's countries like Croatia, where we're going to be one of one, and other little countries like Costa Rica even, where we all should do a due diligence trip and to see the products. But at the end of the day, we were able to become the number one self-payer market extract in Germany. We're the number one primary oil carrier. We can't say number one because we don't know the numbers, but we're the primary oil carrier in the UK for, I believe, 15 out of 17 clinics. In Australia, we reach 486 pharmacies, and I believe it's 36 clinics is the number, as I recall. And so in these larger markets where we're also where we have a dominant extract position, we've also started to layer in flowers, which we think are less. I mean, we're not diminishing the medical quality. Let's say less pharmaceutical. It's a less pharmaceutical product, the flower, than the extracts that go into countries coming out like France, Spain, and all those, which are only extract only. But for the larger markets, we have flower portfolios that are being generated since we bought our own grow here, and now we have a second grow, indoor grow in Portugal that we've contract manufactured. So our demand has increased to a point where we need two grows indoor. We have all indoor flowers, and plus we have about 15 worldwide partners grows that feed us flower for the international markets. And so that's kind of an outlook now. We're still, I believe, number one in country reach in comparison to our peers. But there's really only 5 global operators, brands today in the market, and then a lot of localized brands, clinic brands, white label brands, things of that nature.
When you go into these different countries and making partnerships and starting to make inroads, it's not going in and building facilities and setting up new operations, but it's going in as Somai and partnering with different manufacturers and growers. Is that how it works?
I mean, unlike the U.S. state-to-state model, where you need infrastructure in each state and the borders are not crossable, for the global markets, our main manufacturing all the countries because we're EU GMP, which is the gold standard. If we were SAFRA GMP, we couldn't come over to the EU GMP. If we're Australian GMP, we can't come to EU GMP, but EU GMP can go to any country, including Australia, South Africa, Brazil, and any European, New Zealand, very difficult. Costa Rica is EU GMP. They're all EU GMP. That's usually the highest standard of a narcotic transport and sales. So we just, our products are market authorized products. So unlike a localized market where a compound pharmacist or a local manufacturer may make a singular brand or they have different quality standards where today they say, I'm going to make a gummy, and tomorrow they have gummies in the market. Whereas the EU GMP product, which is a market authorization medicine, takes roughly 2.5 years from the day you start, assuming you have the building to work, the rooms to work under. It takes about 2.5 years to get through validation batches, stability testing, and then regulatory approval for sales to multiple markets. We're one of the only few that own our own manufacturing that could span multi-countries. And so our partners in the other countries are pharmacists or distribution or clinics or hospitals. So generally, in all the new markets, there's not really entrepreneurial cannabis companies. There's just pharmaceutical distributors. So you need to have a pharmaceutical distributor as a partner or open your own pharmaceutical distribution, which is quite simple to do, but it costs money. So for the larger markets, of course, we invest in it. But for the smaller ones, it's better to work with a good pharmaceutical partner to distribute our products that are manufactured in Lisbon.
So everything is manufactured and grown for you in Lisbon.
Correct.
And then you export to all the countries, all the oils and flour if allowable. But now you said you have other cultivation partners, but that's what you're doing is exporting.
Correct. We have partners in other countries that feed product to us. So it could be biomass for extracts. So we have multiple growers in Colombia, South Africa, as well as Portugal. And then it could be like CBD. We don't need to manufacture that. That's an additive to the formulations. So we have a partner in Colombia who supplies us there. But then we don't have enough flower for our demand. So we have other indoor facilities in Canada, South Africa, Thailand, Australia. They are able to transport the product to us for sales into the major markets. So we can process the flower through, because we have 2 EU GMP facilities. And so we can process the flower and sell it. And we also own our own lab, which is very rare for cannabis, but very common for pharmaceutical. So we have our own GMP lab, which means we can clear our products. Even the one lab that exists here in Portugal called, well, I don't want to say the name, but they are not GMP. So if they cannot certify a product like us, where we can certify our product direct for sales, and our COA is the final COA to the patients and the buyers. So it's a ecosystem that has import hubs that we import from, and then we export out the finished products to the other hubs.
Isn't it a conflict of interest to have the lab within house? Like here, you have to have a third party testing lab. It just seems kind of, I don't know, like, we have so many problems here in the United States with the testing labs and.
No, but it's a really good point. When you're at pharmaceutical, it's a different managerial structure. So like just a second ago, I had the QPs, which is a qualified person. The QP runs the QA, the quality assurance department. This is an independent, I hate to use the word police, but it's a good way to say it for the audience. They're like the police that check to make sure all documentation, all procedures of the production team are all captured. Even me, I do not interfere with the QP's decision. What we do though is I can manage, as an example, their efficiency of reporting. So are you getting your documentation in time? Because they're responsible not just for the production team and how they operate. They're responsible for analyzing the lab, and they're also responsible for the people we sell to and qualifying those. So consider them like one unit of check. Now you have the lab, which is its own independent unit of check. Again, nobody is allowed to influence the lab. The lab reports the facts, and there's lots of things that have to go on in production. So you make an extract, you check it, that's the lab. You move it to formulation, you make sure it's the exact formulation, you check it. You get a finished bottle, and you need to check randomly the dosage to make sure that you have exact dosage per bottle. All these checks go to the lab, but then the QP reviews procedures. Did the production team follow their procedures? Did the lab follow their procedures and release it? And then that releases a product into the units. Now, when you think about it, there's only 280 QPs in the entire Portuguese country. We have 3 of them here, and they really, it's their careers and their whole livelihood is being these QPs and being the person responsible. And they're basically, each facility requires a QP, so you must have one. Most people, smaller companies, rent a QP, so they have different standards. We have a QA/QP department. We counted this morning of 12 people plus 3 regulatory affairs, and these are simply to guide the regulatory processes so we can assure documentation should we get an audit by Inframed. We can assure quality standards to our buyers who have to personally come check our quality systems and how we run our company and give an approval. It's really, it's not about the countries of Europe, it's pharma. And I'm pretty sure it's the same in the United States at the pharma level. And, on the state by state cannabis rules, because, okay, I get that. There's none of these pharmaceutical rules to follow because there's no federal legality. So you're pretty much being followed by OSHA, which is restauranteering rules, basically, in some way. And so there is no quality department. There is no quality lab. There is no check and balance in the structure. And these are things that are required for pharma, and most all big pharma has the same structure, and the regulators follow that.
Wow, that's so interesting because, there's a big problem and a big discussion right now in the US because there's a lot of hanky-panky going on with these labs, kind of paying them off to, increase the THC, amounts and all this kind of stuff. So it almost sounds like a better system than, relying on these third-party labs because they're not, it's turning out they're being paid to do whatever someone wants them to do. So this seems almost like a better system. So that's very interesting. I didn't know that because we're really facing that problem. The other thing, it seems the way you're talking about all the imports, exports going on, that there's a lot more trade than I thought was going on between the different countries. So, I guess we need to open it up, but it seems more open the way you're operating in and out of, you're saying almost 18 countries.
Yeah, 12 going to 18. Yeah, look, you have to think of it, when you're a pharmaceutical product, that means you have a pharmaceutical medicine. And it goes like any pharmaceutical medicine, whether you're talking, um, uh, 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 antibiotics you're buying, it's all run in the same exact manner. And that quality standard means it has to be replicable, consistently, and the checks and balances are there for a medicine. So imagine any medicine that you pick up at the store, we're under the same quality standards as that. And so as such, as a authorized medicine, that product can be transferred to any country accepting that derivation. Now, the US is a closed off market because it's FDA regulated, and they're more into synthetic products for their approval process, whereas Europe and other countries also have large herbal medicine backgrounds. And so we fall inside the herbal medicine pharmacopoeia. And so it's still just as rigorous. It's not a nutraceutical, it is a medicine. But as an example, we are working with Veterans Affairs in the United States because there is no extract made in the United States that is medically approved. And when you're on a federal level, you need a medicinal product if you're going to get into that kind of a program. Now, we're unsure the pathway for us, but we are hopeful that as a medical product and unique to the American market, where they can't just walk into a dispensary and say this is compensated by the Veterans Affairs, we're hoping a medical product will be able to make it through those studies under the herbal pharmacopoeia and as a registered medicine in Europe. And so we do that, though, quite regularly for very hard to get countries. So we have 2 FDA registrations in Thailand. We're going to go for 2 FDA registration. It's the FDA of their country, just to not confuse it with the FDA of America, but it's the same acronyms. And the FDA registration in Japan may follow with Thailand. France is also a medicinal registration where the government chooses and also regulates the pricing. So we have to compete with the government on pricing. And in France, as an example, all cannabis is for free. I shouldn't say for free, but in essence, the government subsidizes the payment, and maybe there's a small dispensing fee or something like that. But the point is these are true medicines that travel cross-border unilaterally. And so any country that accepts cannabis as a medicine, we are there to bring products to them, even the smallest ones.
Okay, so I know there's a lot of movement in the United States in the VA, with the VA and trying to get them to accept it and be able to recommend it and things like that. So, but the fact that there's THC in it, I wonder how that would work coming into working with the VA.
Yeah, if you saw about 2 years ago, there was a shipment of medically grade flower from, I believe it was Uruguay, but it came from Colombia. And it came as a medical product into the market. Now, this was, I believe it was 2 tons. This is years ago, so, don't quote me on that one. But that was more for R&D. I know there's, I believe, 5 R&D DEA licenses where they have little small grows that are growing it on that program. And because our product is a medical product, it indeed can come to the United States under a supervised clinical trial, or possibly, we hope, with the Veterans Affairs. And so, like I said, there is no promises out there. There's a lot of politics in this, but we do have a market authorized medicine that can be accepted into the markets with THC, just to be clear.
Mm. So also, like you said, a lot of discussion also in the United States is, about synthetically made or synthesized and not, because it's so hard to replicate the plant because of its variability. But you're at Somai, you specifically work with plant material, with the plant, not with synthetic.
That's correct. Synthetic, like biocatalysis or other chemically formed minor cannabinoids through semi-synthetic processes. Maybe they start with an input of CBD isolate, as example, use chemicals to transform it, or biocatalysis where you're using enzymatic replication. But anyways, we don't do any of that because it's not permitted in our markets. And the only pathway for us currently, without full clinical trials like Epidiolex, Sativex, Marinol, Dronabinol. All these went through full clinical trials. And so the herbal route of medicines, it's the same as any other medicine, but it has a different road where the basic components of THC and CBD are considered safe for human consumption. So we don't need to go through all of those safety standards. We have to go through quality and stability standards to prove that it's a replicable product at a medicinal level. So each product must be the same to the next batch to batch. And so that's more the road that we're trying to pursue over there, but not synthetic.
Yeah, well, I mean, it seems very challenging. And then maybe this is a good time to also mention your research partnership with a university in Lisbon on developing a standardized way to manufacture oil. Can you just tell us about that?
Yeah, really interesting. So it was 3 years in the making. It's our third published piece, peer-reviewed, published study. And the University of Lusofna did a wonderful job of taking the flower start and then the extract process, what is taken out and what remains throughout that process, and then the re-addition of terpenes to match biomarkers to replicate the flower to the best of its ability. Now, this is a dry herb extraction, so a dry flower extraction. So we use cryoethanol, and then we also use a purification process with the VTA 100. And then we have a reconstitution of terpenes because we extract the terpenes as a primary step. So I probably should have started with that. But the point is it was a study to show the replication that we can actually do indeed use the same flower from each product to product, each batch to batch, and that we have to have a consistency in order to claim medical status and prove that. And through the GMP checks and balances, all those testing I told you about earlier, all the data exists for each of the steps. And so each time, every single batch is always tested, and they analyze that data. And I believe this was more of a statement of clarity to the market of what a true quality, because this word is overused in our market. Everybody claims quality, but we tried to show it in a scientific value, what really quality is, and give people the tools to choose for themselves what they consider quality. And where I win with that is there's not many manufacturers that make their own, like we have the largest extract portfolio, but there's not many of us, and many of them are just selling APIs, an active pharmaceutical ingredient, which means you get the bulk oil, and then somebody mixes it somewhere and then puts a label on it and says, here you go, this is filet mignon, this is and here's what we got for you. Whereas we're trying to differentiate ourselves from that changing of oils, that always going to the cheapest oil carrier, that oil is oil market where they're not necessarily putting their name on it. They're putting their name after to make a cheap product, or cheaper product, I should say. So we really want to continue with the pharmaceutical evidence to show that we're different than a lot of the localized production. And so we don't really compete at that level, but they're always nipping at our heels. And we really want to put to bed what a medical product is versus what a compound pharmacist makes in his little laboratory with his vest.
Oh, are you talking about like distillate, adding some terpenes, maybe that kind of, it's like a distillate?
It may be, yeah, it could be like the distillate, and they'll take it, they'll put it in a bottle, they'll put some MCT oil, they'll shake it up, and they'll say, here's your oil, your 25-to-1 dose oil. And so that's what's happening. And they're doing it in these small scales, and they're able to make it look like anybody else's product. But this is compound pharmacists were basically, they're they charge a lot of money for what they do because there's a legality to charging more money. But the basic point is, when there's a lack of medicine in the product, orphan indications, things of these natures, we need compound pharmacists to make those products that don't exist in finished dosage form. But there are rules in the pharmacopoeia, and in Australia, they reaffirmed these rules October 1st of last year and said there's enough finished dosage form applications in the market where we do not need to have compound pharmacists charging more money and making a lesser quality product when the manufacturing steps are so high quality to be able to be sent across the globe, and they have consistency standards in line with the highest of regulatory standards. Well, why are we competing against a compound pharmacy, mixing up a little bottle and shaking it and saying, here it is?
Yeah, okay. I know that it has to go through the pharmacy compounding system, right? So that's how it's delivered to the patient. Is that right? Whatever country whatever country you're in, it is compounding. So how do you get your finished product in there without having them legally, needing to mix it themselves?
This is a really great question. I'm going to try to give you the shorter answer so I don't go too long on this one. Some countries, UK and Australia and others, you could send the finished dosage form product. So it's ready to go. It's in a box, just like any pharmaceutical you get when you go to your pharmacist. They deliver you that product and boom, you open it and you start using it. Yeah, so that's finished dosage form, and it does. Many countries, most countries, I think now, especially the newer ones, even are finished dosage form. Earlier versions, because back in 2017 when these movements started, and really you didn't see products till 2018 and 19. There was a way to get through the system under magisterial prep, and magisterial prep means compound pharmacists will take the flower, they'll repackage it, and they'll call it a compound pharmacy. They'll take the raw oil, they'll put it into the little jar, they'll put the MCT, they shake it up, they deliver it to you. That's your product. And they were needed because there were no manufacturers. Of course not. The manufacturing process, I'm not sure why it keeps doing that, but the manufacturers came later. It's like the chicken before the egg. Everybody always asks me, why is flour so prevalent in the older markets and the newer markets are all extracts? And I point out that in the early markets, there was nothing else but flour. If you didn't grow flour, well, you're not going to make extracts because you have no flour. So you first got the flour. And then people started making extracts. And now, as new countries come on, there's plenty of extracts, that can be made or mixed or formulated. And so now these countries said, well, look, we want to go more pharmaceutical than extract only. Well, few countries like Germany still require a magisterial, which is a compounding step. But what are they really doing, Pam? They're taking my bottle where I have a special cap on it, and they're taking the cap off and they're putting on a child-proof cap, and they're calling that finished dosage form. And we would normally just deliver that finished dosage form with the child-proof cap directly to UK and Australia and others. Well, they require us to have a special cap, which is called a magisterial cap. They spin it, they put a child-proof boom, and boom, they charge double the money. And that's an archaic system that needs to go. As a matter of fact, I'm writing an article on it right now. And it's one of my many articles where I chastise the fact that as Germany grows to $1 billion market, and now they have all these inventory management problems because a compound pharmacy product has a 3-month shelf life, whereas my products have a 2-year shelf life. And so why am I delivering a 2-year shelf life so somebody change a cap and then call it a 3-month shelf life and then have inventory problems when I could build a massive inventory with 2-year shelf life and never worry about it? And then I never have to, I can have a much smaller inventory management team. And so these are things that need to change in our markets as they mature. And I'm hoping that most markets and most regulators start to change this outdated practice. Even in Australia, when they they reaffirmed the rules on October 1st. Nobody paid attention to them. It's quite surprising.
So that leads to another question is so now when you're exporting to different countries and they all have these different regulations, or like, Germany, what you were just talking about, or you can ship to Australia a finished product from your lab. What would it take to change that specific law in Germany? Like, I'm just like one example of how we're trying to harmonize this cross-border distribution.
Complicated. There's very powerful powers to be. The pharmacist lobby group is very strong, and now you have 2,000 pharmacies, I heard, in Germany selling cannabis products, and they get 90% legal margin. Whereas if they sell an antibiotic, maybe they get 5 or 8% margin. So it's hard to fight those financial incentives. Although I did write to a professor the other day, and I said, "How do we? Our products. I have a 200-page market authorized dossier. Maybe there's a way for us to say, look, I don't see why we're in this with this old way of doing it. We would like an application to bring in our products under finished dosage form." My guess is they may require clinical full trials in order to get a full market authorization for them. Or they may look at it and say, well, it's not a narcotic anymore, and they do conform to the market authorized documentation. Same with Portugal, we have the same dossier in its finished dosage form. Same with Poland, same with France, same with Spain, and they all accept our products under that format. So maybe they will look at it from their point of view, which is standardized across Europe, and say, well, even though we were doing it this way, we should conform to the EU herbal pharmacopoeia and accept this. I don't know the answer to that question, but I am surely concerned about it.
And it's also adding cost to the consumer. I mean, it's adding unnecessary cost because somebody's got to pay for that if they're charging this. And that's going to be, it's going to be the medical system, the reimbursement system. So it's a big mess. Yeah. I mean, we all have our little things that we have to fix, but I was not aware of this issue in Germany. So that's really interesting. So I guess also how, like, with all these different obstacles, I guess, how do you see what is the need to harmonize? I guess this is one example. Just, to harmonize the whole, let's just say even the EU. So where do the rules come down? Is it from the European Commission, like the ones you were saying that you follow, like in Poland? And do you all follow the same standards when you're whatever countries are allowing imports or exports? I guess
Yeah,
I think, what is the solution going forward? Actionable solutions, I guess.
yeah. I mean, there's an overall guiding principle to pharmaceutical manufacturing, and that's the pharmacopoeia. And so we follow the EU herbal pharmacopoeia. Basically, that's what everybody follows for any medicine. And it's been, I think it's constantly updated and developed and addressed by a large board of directors that guide all of this. It's like a corporation above that that guides pharmaceutical standards for us, kind of like the United Nations of Pharmaceuticals. And then each of the individual countries, the regulators, they have their job to enforce whatever the rules are for that country. Now, where do those rules come from? These rules, especially cannabis, because it became a country by country decision to adopt cannabis policies, that rule is guided by the FDA, the HHS of each of these countries. So in Germany, it's called BfArM, and in Portugal, it's called Infarmed. And so politicians make a vote or decision to open up cannabis medically or other. Pretty much it's all medical, to be clear. And then those rules are translated by a health department and regulatory agency. You could watch Spain doing this right now, and we're waiting for the final proposal of regulatory rules, which are made by that local government. Now, they're based off of the pharmacopoeia for medical products, but they may add changes to it, like medical very hard. These are my terminology, medical heavy countries. They may say, take the strict approach that only clinically proven indications are acceptable. So multiple sclerosis, stage 3 cancer, epilepsy, these. And that's super medical heavy. That's like New York a few years, 8 years ago, whenever they started. Then you have, when you add the category of pain, which is about 80%, the general category of pain, 80% of prescriptions today are based on that. Like Ireland is expected to. Spain added pain along with all those heavies. Well, you're not necessarily medical medium, but you're a little less, you're medium to heavy. And then once you start opening up to anxiety, stress, sleep, and other mental or lighter disorders, then, okay, you're at medical medium verging to light, and then you get rid of the narcotics. It's no longer a narcotic in Germany. Well, now you're medical light. It's like paracetamol 1000 or a heavy aspirin, a prescription or an antibiotic. It's not a serious, like a narcotic. And so those independent regulatory frames, how they want to treat their population, how they want their population to use that cannabis, is based on their local cultures.
I don't really know there's really an answer. I guess we just have to get the regulators on board and the lawmakers and convincing people of the efficacy of medical use of cannabis, I guess.
Yeah, I mean, look, barring all the people, the groups that have vested interests for cannabis not to succeed, big pharma with their pain medications, big beverage watching every state with cannabis going down in the uses of alcohol rather than a nice steady upswing continuously. Obviously, these are not positives for them, but positives for the people that are using it. I think what would be really great is if the U.S. got their head out of somewhere and got a Schedule 3 going, which is common sense to everybody. If a Schedule 3, it's not that it would change our business in the United States. My business is in the United States, but it would change the global community's view on medical cannabis. Because if they adopted a Schedule 3, it is a medicine, which is common sense at this point. We know that's political. If they adopt that, well, every country reads about that and has to make an adoption. And what ends up happening is they start to homogenize by looking at each other's markets and finding the best solution for their culture. And we don't expect everybody to drop the narcotics definition tomorrow like Germany did. Clearly, that's kind of like Canada going full-blown rec as a country. Not many people followed that path, but states did, and countries will, and they may individually decide that, but at least there'll be a broader access, which is all I really hope for, is that people who want to get the medicine can get it as easy as they can in an ethical manner.
Going back to the herbal medicine approach and using the whole plant instead of synthesizing. So are you working with specific cultivators to identify specific strains, for these indications? Because I know at Somai you have a lot of different, your products, are directed towards specific indications, very customized for all these, different things. So how are you finding a plant that has all those, compounds or cannabinoids that would treat this specific thing? Is that something you're working on also?
Yeah, it's a great question. Of course, we have many different extracts that we tested, used years ago, right? And we settled into ones, in one way we were able to use empirical evidence of why people were smoking that one flower as an example. And we were able to at least analyze, what were the qualities of it, the minors, the terps, whatever, you want to base your knowledge, whether you believe in entourage or not. It seems like people are split 50-50. Of course, I lean on that side because we have a lot of formulations that involve terpene formulations and stuff like that. Well, we had to pick out those. But the one thing we can't do, Pam, is we can't make any claims as to what it fixes because we've never gone through full-blown clinicals, which we do not have to in herbal medicine. But the converse is we cannot make a claim that it's that. What we can show to doctors and clinics is based on people's common usage, we found a correlation to this plant. But we can't say that that's perfectly exemplary of what will happen because there's nothing to prove that. So I think it's something, it's not for us today because it requires tens of millions of dollars. But I think if we get a little better understanding, I mean, we do have our bestseller, and we don't necessarily know what the patients feel besides what they publish online, because that's between doctor-patient privilege, just like HEPA laws in the United States. But we do have partner clinics that are analyzing different usages, palliative care, of course, different pain, different pain categories they're using it for. And so they do give us anonymized data, but it's just too small to make a true set, to make a full. So we'll have observational trials, but not full-blown clinicals where we could show evidence of what we've tested with their patients.
I know we're at the beginning of all that. I certainly understand that. And I'm watching, the different research, that's happening here. We have a few happening here at some universities, like it's Johns Hopkins University, things like that. So I know we're at the beginning of that. But anyway, it's just very exciting. And thank you so much. I really appreciate you joining me today.
Well, thanks for having me, Pam. It's always a pleasure seeing you, and I love your questions. You always get the provocative ones.